Good evening, everybody. Thank you very much for dialing in tonight to listen to me talk about stroke and what's changed in pre-hospital stroke care. So I'm Graham McClelland. I'm a research paramedic from Northeast Ambulance Service. I'm also a clinical researcher attached to a stroke research group at Newcastle University, very kindly funded by the Stroke Association, who've backed my particular research over the last nearly 5 years now. So I owe a great debt to them. But I think I was asked to come and talk about this tonight as I was involved in updating the JRCALC stroke guidelines. So we will get around to what's changed in them, what's changed in other things affecting pre-hospital stroke care, and maybe a little bit else is going on in terms of pre-hospital stroke research. All right. So what's changed in pre-hospital stroke care? Actually, from frontline paramedic perspective, not very much. Practice now is pretty similar to how practice was 5 years ago, 10 years ago, maybe, perhaps longer for most of us. It doesn't look like a lot has changed. Dispatch for stroke is still pretty similar to the way it was. We're still using the fast test and taking people into nearest stroke unit with very little we can actually do for them, it feels like. But actually, there has been quite a bit happening behind the scenes, and there has been quite a bit published and released over the last 18 months or so that will affect our practice, if not now, but certainly going forward. And that's what I'm going to go over. And I know people have been a bit distracted over the last 18 months or so. There's been a few things going on, but hopefully I'll show you that there has been some work going on which will be affecting your stroke care in the coming years. So what I'm going to run through at first is 6 particular publications, as I say, all from starting back from March last year, all of which, if not directly changing things now, will change things for us going forward. So, first one, publication March last year, Utstein recommendations for emergency stroke care. Now, paramedics were very familiar with Utstein, but we're very familiar with it from a cardiac arrest point of view. And Utstein criteria have been used to drive cardiac arrest care for years now. And certain systems, the Seattle Medic One, King County, Global Resuscitation and Symposiums and Alliance, use the Utstein recommendations and their guidelines to drive cardiac arrest care, and they're known for implementing that. But the Utstein approach was put to stroke care back in 2018, or a group of international experts met together at the Utstein Abbey in Norway and started discussing what could be done to improve emergency stroke care, because this is a massive problem, and worldwide you're talking about 15 million strokes a year, and nearly half of the people who suffer a stroke will die from that. And the scale of this is absolutely huge. So over a period of time, and as I say, the publication came out last year, they put together Utstein for stroke. And part of that is this chain of survival. And again, chain of survival is something we're all familiar with, but this is for stroke. And if you look through it, bystander awareness, familiar with that, dispatcher recognition, ambulance, pre-hospital care and triage, hospital rehab. So right the way through the chain of care. But parts 2 and 3, dispatcher and ambulance, that's us. That's our ball game. That's where we're working. And within this, they had a sort of 10-step program, again, based on the Utstein process for cardiac arrest, for improving stroke care and improving stroke survival. And these are quite high-level targets, quite high-level guidelines. And if you go and read the paper, there's an awful lot in there and a lot of supplementary material worth having a look at if you get the time. And what they recommend is, or what they say is, you've got to focus on each element, improve each element right the way through from symptom recognition to definitive treatment. And this is how we're going to improve stroke care and improve survival. But one question I would ask is, we know some of the systems, as I mentioned earlier, one, Seattle Medic One and Co, that are renowned for the, pushing forward with the cardiac arrest care. But who's really pushing forward with pre-hospital stroke care? Who are the systems we should be learning from? Who are the best in the world at delivering this? And why don't we know about them? What can we learn from them when we find them? And this is just a question I would ask you. Okay, so Utstein recommendations, big guidelines, quite high level. Something a bit more local and a bit more relevant to English UK ambulance practice, I think most of us are probably talking about here. So NHS England produced an ambulance stroke pathway. And this came out last year. So I've split it into two parts because it's quite small. So this is the first half of the pathway. And starting from, again, public awareness, but call taker recognition and this dispatch recognition of stroke and AMPDS, NHS pathways, how we recognize stroke, how we dispatch an ambulance to it. And this actually impacts on the care right the way through. And yet it doesn't receive the same amount of attention as face-to-face, clinician at the scene. But it's the recognition of dispatch by the contact center that starts that whole chain in motion. And if the dispatch recognizes it as a stroke, the paramedic on scene is more likely to recognize it as a stroke. And therefore the whole chain of care carries on to get this concept of diagnostic momentum. If the dispatcher doesn't recognize it as a stroke, then again, it can have negative impact. It can impact on the time we spend with these patients. Time is, of course, important for strokes. But what you'll notice is down the right-hand side of this pathway, they've got recommended timings. So call to dispatch within 2 minutes, dispatch to arrival based on the category of dispatch. But this becomes more interesting when we get into the next slide. So this is getting into the sort of the clinical, the face-to-face side of things. So there's a lot of stuff in this pathway, but there's a few things I'd like to pull out. So a recommendation for how long we should spend on scene with these patients, less than 30 minutes. Now, to me, that's quite a generous target for how long we should spend with a stroke patient. Stroke is a time-critical emergency. The American Heart Association, their target is 15 minutes on scene. And that's maybe ambitious, but 30 minutes seems quite generous. But the gist of it is we need to minimize on-scene time. Green box on the left-hand side of the screen, if you look in the middle green box, consider digital aids. Now, this is something that some services are starting to introduce, apps to help with the decision-making and knowing which is the nearest hospital, what pathway you should be following, but maybe not something adopted widely yet. But digital aids, technology is something that's going to come through time and time again in the things I'm talking about. Right in the middle there, in the yellow box, telemedicine. And I'm going to come back and talk about this a bit more later on, but telemedicine is a consistent theme coming through all these recommendations on what we could, should, are using to support and improve the pre-hospital stroke care we're delivering. If you look across on the right-hand side, we've got a TIA pathway, and there's going to be changes in the JRCALC I'll talk about there. And then across the bottom, so this pink bar across the bottom, data review and ambulance feedback are key to improving stroke care. Now, how many of us get feedback on the patients we take in? How many of us get feedback on the stroke patients we take in? How many of us get that feedback to use it to reflect, to improve the care we deliver? I'm not sure many of us do. I know there's pre-hospital post-box. I know there's some initiatives in this field, in this area, but I think that feedback would be really, really useful. And black and white backed by NHS England. So hopefully maybe something you'll see coming sometime soon. Okay, let's move on to the next thing that's changing, or hopefully going to change for us in pre-hospital stroke care. So SNAP, the Sentinel Stroke National Audit Programme, is the national stroke audit. So all the hospitals submit data on all the stroke patients and get scored on this and get benchmarked. And it measures the quality and helps drive the quality of stroke care. SNAP from next year's report will include ambulance data. So the ambulance services started submitting data to SNAP, linking up our data, our care of the patients, what happens in the acute hospital, right the way through to discharge and rehab. We can start to look at the whole patient journey. And this, I think, will be really useful for starting to see how what we do in the pre-hospital setting impacts on the in-hospital care and impacts on patient outcomes. And we can use that information. So the SNAP produced an annual report. This one was January 2021, so beginning of this year, this was published, and looking at stroke treatment here, the sort of treatments, the acute treatments that our care directly feeds into and influences. So thrombolysis, the thrombolysis rate across the country is around 12%, 10 to 12%, and has been there for years. It really hasn't changed that much. And that's against a target of 20%. They reckon we could be thrombolizing like 20% of acute strokes, and yet we're in a steady target of 10 to 12%. Thrombectomy, there's a target there that's been set. They reckon up to 10% of strokes could be eligible for thrombectomy. 1 to 2% getting it. Thrombectomy is very new, has been offered primarily through research studies and through small centres. It's not available 24/7, certainly not available widely as it will be. But there's a target there, and our care again will feed into this. And thrombectomy again is a theme I'll keep coming back to. So if you dig into this report, there's a few more interesting things now that are a bit perhaps more relevant to us. So door to needle time, this measure of how fast people get thrombolysis once they hit the hospital. And over a 7-year period, they've driven that down from 58 minutes to 53 minutes, so 5 minutes shaved off that. And that's good. That's good for patients. Earlier thrombolysis, better outcomes. But if you look at actually the time from onset of symptoms to arrival at hospital, before that door to needle starts, that's gone up over the time period. That's gone up by a lot. 50 minutes, nearly an hour added on to that, which sort of dwarfs the 5-minute savings in hospital. Onset to arrival includes our bit of care. It's not purely our bit of care. This also includes the delay between the onset of symptoms and calling for help or recognizing there's a problem. But the pre-hospital time, the ambulance service time, does contribute to this. And myself and Dan Howarth in the Northeast did a little bit of work on this a couple of years ago and showed that in our own service, our times were going up year in year and year and year. Both call to arrival, on-scene times, and leave seen to hospital were going up, so contributing, and across again a 7-year period, more than 20 minutes added on. And this is not what we want to see, really. We want to see times going down. We want to be doing faster stroke care. But we are not the total part of the onset to arrival, but we're definitely part of it. And that's something that, again, I'll come back to, but we could be improving. Okay, so at the end of the SNAP report, they talk about where they want things to go and their recommendations. And they talk about this 20% of target for thrombolysis. But big things pulled out of this: focus on pre-hospital systems, close collaboration between ambulance and hospital services. So we know we have to work closely. We're part of the patient journey here, how we interact with the hospital services, how we hand patients over, how we notify them, our dealings with them, the feedback we get from them will all feed into this efficient acute stroke care. And the more efficient we can make it, the better the outcomes for patients. Pre-alert systems we're using, we know how to use them. Pre-hospital diagnostics, there's work going on in that area, but not much other than variations on FAST, although a couple of services are using different things I do recognize. So SNAP's giving us some data on what's going on, both, or we'll have ambulance data, but across the patient pathway. So worth look at and will drive care. So we're getting quite up to date now. So May 2021, the National Stroke Service Model was published, and this includes what we call ISDNs, integrated stroke delivery networks. These are sort of regional, super regional bodies that are going to drive stroke care in particular areas. The ambulance services are partners in these. We're represented on the ISDNs, and this is all about focusing on stroke care. And when you read through the National Stroke Service Model, there's a chunk on pre-hospital care, which we'll pull the bits in a second. But it talks about changing some of the language we use to talk about stroke care. So we're moving away from HASUs, these hyperacute stroke units. We're going to talk about comprehensive and acute stroke centres. So comprehensive stroke centres are those centres that will have neurosurgery and will deliver thrombectomy. Again, this is going to become increasingly important. The stroke service model talks about how we're going to deliver thrombectomy. And pre-hospital is a thread running right the way through it, as is the use of SNAP data to drive care and improve care. So this is a big view of the ISDNs, talks about patient information, data, systems in the urgent care, ambulance services, front and center. We are part of the patient pathway. We're an important part of the patient pathway. We are the primary route into care for the majority of people having an acute stroke. We are their first point of contact. What we do with them is important, and it is recognized. And if you look along the bottom, we're talking about thousands of premature deaths and tens of thousands of disabilities. This is something that, you know, we can directly impact, even though maybe it feels like you don't do so much with these patients sometimes. Okay, so within this, there is 2.5 pages dedicated to pre-hospital care, and pulled out some of the highlights here. So it talks about the category 2 response, and this is our standard response to an acute stroke patient within a certain time window. And that time window is certainly discussed because in-hospital stroke care has maybe moved on in some areas past the standard sort of 4.5-hour thrombolysis window that our responses tend to be dictated by. So there's certainly some discussions going on at quite high levels around the category of stroke responses for ambulances. Talks about improving the response and reducing the on-scene time. We know the on-scene time contributes to that onset to hospital time. We know that's been going in the wrong direction, so we need to make efforts to reduce the on-scene time. Accurate identification. You know, we need to recognize it's a stroke to get to the right people to the right place, but how we recognize that is, you know, there's a variety of tools, there's a variety of versions of FAST out there, and there's a variety of diagnostics being trialed to improve our identification of stroke. So this is recognized that these are coming. Telemedicine, again, coming through and consistently in all this documentation. The use of audio, visual, FaceTime, Skype, Zoom, whatever your platform you want to use, telemedicine to connect us in the pre-hospital setting to the in-hospital specialists, to the stroke unit who are going to be receiving and looking after these patients or helping us with their expertise in order to make the best decisions for the patients. Telemedicine is getting recommended throughout all of these things. So previously in the SNAP report, we talked about door to needle, and historically a lot of stroke care and acute stroke has been measured in terms of door to needle, but we're now starting to talk about call to needle, recognizing that the patient care starts from the first call for help, and we need to measure it from point of call through to care, definitive care, whether that's needle for thrombolysis, thrombectomy, or admission to a stroke unit. We're talking call to needle now. So changing the language, changing the targets, and we're linking up the pre-hospital care with the in-hospital care. And thrombectomy patient transfers are a bit of a bugbear for some people and a slight problem at the minute, because patients, there's very few hospitals. There's only going to be 24-ish in the country delivering thrombectomy. It's going to be like PCI, it's going to be like your major trauma centers in terms of the model. But how you get the right patients for that treatment to the right centers at the minute relies on going to your local stroke unit and then getting a secondary transfer to to the regional neuroscience center. And those transfers should be a Cat 2, the minimum of a Cat 2. But we all know that the ambulance service is under a lot of pressure, and a Cat 2 into-hospital transfer may take some time, and these patients are deteriorating. Thrombectomy, like thrombolysis, is time dependent. So what can we do, the Royal We, in a system level, to improve the care, to get these patients to the right care faster? And then TIA services, again, the fact that we need access to 24/7, 365 days a year, TIA services. If we in the pre-hospital setting have any chance of referring them on and taking them anywhere other than EDs or the local stroke units. Again, something to have a look through, but just the highlights of what's talked about in that report relevant to us. Part of that report as well, the long-term plan, again, coming back to the aims, preventing heart attacks and stroke. Or, you know, if we could prevent it, it's much better than treating it. Much else we didn't have a stroke in the first place. Talk about mechanical thrombectomy, the importance of this, and improving the workforce, we can deliver more thrombectomy. Tenfold increase in the proportion of patients receiving thrombectomy. It's a huge part. Pre-hospital care, pre-hospital identification of patients for thrombectomy or rapid transport to appropriate centres is key to making that work. And best performance in Europe for thrombolysis. These are big ambitions that we're going to need to be. Okay, the bit that probably got me into this in the first place, the JRCALC stroke update. So this was an update. This wasn't a rewrite. This was tidying up, bringing up to date the previous version of the JRCALC guidelines, which were done in 2016-ish, I think. And the reason these were updated was there was a meeting at the beginning of this year between the ambulance service medical directors, where Dr. Deb Lowe, who's the National Clinical Director for Stroke, and Dr. David Hargroves came along. David Hargroves was the GIRF lead for stroke and is an urgent and emergency care lead for stroke now, came along to talk to the ambulance service medical directors about what was going on at a national level with stroke. And out of this meeting, myself, Dr. Scott Munro from CCAM and Professor Tom Quinn were asked if we would update the stroke guidelines, see what had changed, see what needed tidied up, see what we could do to bring them up to date. And over a period of 6 months, this came together. Nothing massive changed. There hasn't been any dramatic changes in pre-hospital stroke care. This is a refinement and an update, but some of the things that were tweaked in the guidelines, just for sort of highlighting some of the things here. So updated the references talking about Utstein stroke, what happened in 2019 with the NICE guidelines being updated, started to talk about thrombectomy, which hasn't really been sort of on our playing field before. In terms of assessment and management, there's nothing really new there. It's focusing on the sudden onset of symptoms. It's trying to, be aware of, people, we know what stroke look like. We know what the symptoms are. They haven't changed. There isn't any new symptoms that are suddenly found, but it's being aware of the range of ways in which a stroke can present and this sudden onset of some neurological difficulty. Definite recognition that technology is going to affect pre-hospital stroke care going forward, starting to recognize that telemedicine is going to be part of care and is already care in a number of services. And the fact there's a wide range of diagnostic technologies being developed, some of which, one of which, any of which would work. If any of them work, hopefully they'll come through into our care. We need something to help us diagnose stroke. We wouldn't go out to a chest pain without an ECG now. We need the equivalent for stroke. We need something to help us, because the sort of symptom-based tools all have their limitations. So there's recognition in the guidelines that these may be coming. TIAs, yes, this keeps coming through again. The change ABCD2 is out. This potential based on the NICE 2019 guidelines, that TIA patients with totally resolved symptoms could be referred to a TIA clinic, given an aspirin and left at home, not taken to an ED, not taken to a stroke unit. And I know some services have pathways for this, but some don't. It seems to be very variably applied across the country, but there's definitely recognition that this is the way that TIA care is going. But this relies on the hospitals having those 24/7 TIA clinics that we can refer into. And I think, again, that's very patchy across the country. There was recognition of the work done in Greater Manchester in the NWAS around their intracerebral hemorrhage pathways, the recognition of anticoagulants, I'll talk a bit more about at the end. And then we also got PASTA into the JRCALC guidelines, the Paramedic Acute Stroke Treatment Assessment Trial, led by a team up here at Newcastle. This was a big trial across 5 years, involved 3 different ambulance services, looking at the data, how we assess and collect data on a patient, a pre-hospital stroke patient, and how we hand that over in the most efficient way to try and drive care in hospital. And we managed to get the PASTA trial was published a few years ago. The health economics is out there. The qualitative data on what the paramedics who were involved in the trial thought of it are all out and published now. And based on that, PASTA was included as a recommendation for potential use in the guidelines. So nothing massively changed there. It was more a refinement, a fine-tuning, a tweaking of our guidelines. And if I had to sort of summarize what the guidelines really wanted to get across, what can people do now? What can people take from this in terms of how to sort of deliver the best stroke care? It's about reducing the time we spend with these patients. These are time critical patients. It's about considering what you're doing, whether you're doing a 12 lead, whether you're cannulating the patient, considering the time these take against the benefit for the patients and balancing that in your head and having a good justification on why you need to do this now or whether it can wait. And remembering the pre-alert and how important it is to let the hospital know you're coming and what sort of patients you've got. And again, recognition that that may well turn into telemedicine for some people. So those are probably the sort of the essence of what was in those guidelines that we're trying to talk about. Okay, the most recent, I think, of the documents I was going to talk about. So the James Lind Alliance did a priority setting partnership with the Stroke Association and a range of people over the last 2 years. So they started back in July 2019, and they asked the public, they asked the academics, they asked the researchers, they asked the clinicians, they asked the patients, what are your priorities for stroke care? What do we need to research? What do we need to improve? And over a 2-year process that took nearly 4,000 questions, topics, priorities, boiled it down into nearly 100, and then boiled it down into a top 10 for prevention, diagnosis, pre-hospital and hospital care, and a top 10 for rehab, which were published in June 21, so only a couple of months ago. Out of the top 10 for prevention, including the pre-hospital section, basically, I've given you the top 6 here because 3 of these top 6 priorities are relevant to us. Number 1, stopping stroke happening, prevention. Not traditionally our ball game. I'll come on to some research and some work in that area a bit later. Number 2, how can the public, paramedics, we're recognised in there, other healthcare professionals recognize and respond to stroke or TI better and more quickly? The speed of our response and the actions was the second in the top 10 priorities out of a 2-year programme of what needs to improve in stroke and healthcare. And this is, again, came from a range of people. And then if you look, skip 3, 4, 5, number 6, proportion of patients get clot retrieval thrombectomy treatment. So thrombectomy is up there in the top 10 as a priority for where the research needs to go, where the money needs to go, what needs to improve in care. And what these priority setting exercises do, what publishing stuff is it drives research and it drives money. And this has already actually led to a call from a scheme called SBRI, which is a small business research initiative, which is a partnership with some academic health networks, for research into pre-hospital recognition. So that, based on these guidelines, they put money out there to say, right, who's got things that can help answer these questions, and we'll put money behind them. And that competition closed earlier this month, and hopefully we'll hear of research coming down the line, which then may lead to changes in patient care based on these guidelines. So this will inform where the money goes and hopefully what happens in care going down the road. So I started off saying it didn't look like much had changed in pre-hospital stroke care. And yet actually there's a lot of things going on, behind the scenes that are going to drive pre-hospital stroke care going forward. But the 3 consistent things I think that came through in all of that work, all of those documents, all of those guidelines and flow charts, is the emphasis on time. Stroke is a time critical emergency, and the times are going the wrong way. All the data says we're spending longer and longer with stroke patients. So we need to really think about that. Technology is going to change the way we deliver care, whether it's apps, whether it's telemedicine, whether it's diagnostics. Technology will change care and is changing care in some services already. And the treatment, not just thrombolysis anymore, but thrombectomy, this treatment for large vessel occlusion strokes, which are very disabling, have a very high level of morbidity. There is a treatment out there which wasn't there 10 years ago now, and we need to get pathways and protocols in place to deliver that. So time, technology, and treatment come through to me consistently from all of this work. Okay, so what is actually changing at the minute? What's going on in pre-hospital stroke care? What's going on that's going to influence pre-hospital stroke care? So we've talked repeatedly about thrombectomy, about treatment for large vessel occlusion strokes. How do you recognize a large vessel occlusion stroke? What's different between that and the standard stroke. Why is FAST not going to pick this up? Well, there's a lot of LVO stroke tools being published at the minute. There's a lot of work going on around how we can accurately diagnose this particular type of stroke, because if it's going to be transporting them to a regional neuroscience center, like a major trauma center, you want to make the right decision. You don't want to take the wrong patient an hour up the road to the regional neuroscience center, which might delay their access to thrombolysis if they're not the right patient that's going to get the right treatment in that hospital. And this was from a paper published by a paramedic called Wayne Loudon across in Australia a couple of years ago, showing some of the scales that have been developed and tested. And if you look, they're all actually bits and pieces of the NIHSS, the National Institute of Health Stroke Scale. You'll recognize most of these things: facial palsy, arm motor, gaze deviation, dysarthria, level of consciousness, visual field. These are things that are probably part of people's practice, but it's which combinations of these would reliably indicate somebody was having a large vessel occlusion stroke. And there's a lot of other tools out there now. There's some with up to 20 different variables in, and that's a lot of things to remember and a lot of things to test. I think we work best with simple scales which we can apply and hopefully get a good answer out of. But the performance of these tools isn't stellar. And if you look along the populations being tested on, not massive yet. We need better data on how these perform in real care and whether we can get one of them that's accurate enough to diagnose a large vessel, or suspect a large vessel occlusion stroke, and get a patient through the thrombectomy. So there's lots of work going on around these type of tools at the minute. One of the problems I mentioned earlier on is that the current model is you take the patient to the local stroke unit, then they get scanned, then they get tested, then they recognize it's a large vessel stroke, and then they have to do a secondary transfer to the regional neuroscience center. And this door in, door out time is generally an hour to 2 hours. And when you've got a time dependent treatment, that's a long time. So there was a nice little project across in Ireland, which was published July this year, looked at actually the crew that brought in the patient to the first hospital. If the hospital thought it was a large vessel stroke and they might be going, they kept a hold of that crew and used that crew to take them straight on to the second hospital. So rather than the crew dropping them off, heading off to the next job, then the hospital having to request another crew for a C2 transfer, that crew, and use them to then go straight to the neuroscience center with the suspected large vessel stroke. And this this more than halved the door in, door out time. It reduced the delay to thrombectomy for these patients dramatically. Nice little project, maybe something that would be considered. It will have a knock on your job cycle times, so therefore there's a downside to it for us. But actually, in terms of getting the patients to the right care faster, maybe something that will be thought about going forward. If we're talking about recognizing large vessel strokes, we're talking about recognizing all strokes, we're talking about diagnostics. There's a range of diagnostic technologies being tested in the UK and abroad at the minute, from visors, the cerebrotech visor on the top left, EEGs, dry EEGs, some using an awful lot less electrodes than the one you see here. There's been some work done in Australia, there's some work done across in either the Netherlands or Denmark, somewhere in Scandinavia, looking at EEGs. There's work done looking at biomarkers. There's a range of biomarkers being tested for acute stroke diagnosis. And these are all looking to improve our ability to diagnose a stroke, the accuracy of our diagnosis, and therefore the care we can deliver and getting the right patient for the right care. A lot of work going on in this field at the minute, not just in large vessel strokes, but in all strokes. Can't talk about what's going on in stroke care without talking about mobile stroke units. We've got Dan Phillips from East of England here and some of the team that involved in the mobile stroke unit down there. I'm not really going to go into this. There's a lot of literature and a lot of people talking about the benefits of taking a CT scanner to a patient rather than taking a patient to a CT scanner. Other people can talk about that far better than I can. But in terms of what's changing pre-hospital stroke care, we can't ignore this. The Germans, the Australians, the Americans have bought into this in a big way, and we'll have to see what happens to it on UK soil. Telemedicine. So recommended throughout pretty much all the guidelines we talked about, this ability for us to access specialist care, to bring the specialist care into our pre-hospital setting. East of England Ambulance Service are using this. I know South East Coast are using it. London, I think, are using it as well. You know, it's coming into practice, and the pandemic, the last 18 months have really driven a lot of healthcare online. And this is sort of one of the ways in which we pre-hospital care EMS paramedics are looking to apply this in terms of, can we use this to help our stroke diagnosis and direct the stroke care we give. There's pros and cons to this, and you need the robust IT, you need good signal, you need, you know, the receiving stroke units to be on board with this. But some of the early evidence suggesting it can reduce the rate of mimics going to the stroke unit, and it may be able to speed up care for those acute stroke patients when they get there as well. So, you know, at least 3 services already trialing this and using it, and I suspect it's going to be coming to more of us with the push from everybody that thinks that the push through all the guidelines to use telemedicine. I mentioned earlier, preventing stroke would be better than curing stroke, and if we could do that, that would be great. And I don't think, you know, we've traditionally thought of prevention as part of maybe our role historically, but we know that actually the big causes of stroke, the big risk factors, your AFs, your hypertension, your cholesterol, your smoking, your blood pressure, your diabetes, a lot of these things are identifiable, preventable, treatable. You can reduce the risk of having a stroke dramatically. And there has actually been some work starting in this field, and I've been involved with 2 projects so far. So the first, led by a medic called Emily Heppenstall, looking at patients, non-transported ambulance patients, so patients that we go out, assess, and refer on to other healthcare services or don't take to hospital. And what she did is she looked at all the ECGs recorded on these patients, and then she looked at the medication and the medical history on these patients, and she found so non-transported patients, so a small, you know, maybe up to a third of the patients we see, 10% of those had AF on their ECG. And out of those 10%, 20% of them had no documented history of AF and no medications for AF. So as a population potentially eligible for treatment, and we know anticoagulation treatment for AF reduces the risk of a subsequent stroke by up to 64%. There's a huge risk reduction. And we know there's a big undiagnosed, potentially undiagnosed, untreated population out there with AF, because people live with it for years. They don't recognize they have it until it's picked up at a screening, they start getting palpitations, or they have something like a stroke. So what about if we could start picking up some of those AF patients as incidental findings when we're out for the epistaxis, the chest infection, the UTI, whatever else we go to see them for, and referring those patients on? And that's what Emily's work was starting to point towards. Another colleague of mine, a paramedic by the name of Josie Taylor, has been doing some work on this as well, around paramedics' thoughts on how we engage with cardiovascular risk factors. And the paramedics she spoke to, and just a very nice little piece of qualitative research, said they thought that patient education was part of their role, and actually referring patients onto these services, identifying these problems, even if it wasn't what they were called for, was part of their role. So there is a role for us in this screening, public health, and possibly risk factor identification. Prevention of stroke would be much better than cure, but as I say, I think this is not much work in this area, but there is some bits starting to pick up. We talked a lot about treatment for ischemic stroke. Hemorrhagic stroke maybe hasn't had the same dramatic changes, but there is some work again going on around hemorrhagic stroke and what can be changed in that. And there's been some work particularly done in Greater Manchester, Northwest area. And this particular Dr. Adrian Parry Jones down there doing a lot of work on this and develop a care bundle to improve hemorrhage control and treatment in hospital, but also with some work going on pre-hospital in terms of identifying and pre-alerting patients with stroke symptoms, but on anticoagulants to hospital so that they can get anticoagulant reversal early. And if you reverse the anticoagulation, you can reverse or slow down the bleeding and hopefully improve the patient's outcome. And they've actually extended their window for pre-alerting out to 48 hours. And as far as I'm aware, they're probably the only service that's gone that far with this. And I think they're possibly leading the way in some of the care we're delivering for stroke in this type of area. So there is some work going on around cerebral hemorrhage care as well, although I don't think it gets the same amount of attention as the ischemic strokes. But beware of your patients on the anticoagulants, the warfarins, your heparins, your apixabans, your dabigatrins, your roxabans. Beware of those patients and take note of what they're on. Talked a bit about TIA pathways, the recommendations from NICE that patients with a fully resolved TIA can be given an aspirin and referred on to a TIA clinic. I said how we need those TIA clinics to be in place for this to really work. There's been a few bits of work around this. There was a TIA study in Wales, and Welsh Ambulance Service led by Nigel Rees looked at this, actually found small numbers of patients. The benefit of aspirin is pretty clear in these patients. The obvious risk is if they're actually having a hemorrhage, but actually the data seems to suggest even patients with a hemorrhage, and aspirin won't do them much harm. But our guidelines and our pathways still don't seem to have consistently applied this. And if you read the NICE guidelines, actually down in the detail, it even suggests we could be recommending aspirin over the phone in the same way we do for patients with chest pain. And again, I'm not sure that's been taken on by any services yet. One word of caution I would raise here is that if you look at the data on patients going to a TIA clinic, up to 50% of patients referred to a TIA clinic, and this is patients referred generally by a physician, up to 50% of those patients don't have a TIA. I'm not sure how good we paramedics are at diagnosing TIAs. I don't think there's much data out there. And that's the risk, I think, and that's maybe the concern and the caution that's maybe stopped people applying these guidelines and bringing them into practice. It's the accuracy of our TIA diagnosis and how confident we are with that, and especially if we're not taking the patients to hospital. But again, one of these things to watch this space and see what develops over the coming years. I'll finish off in a second. There's a couple of pieces of work I'm going to mention here. So this is one of my own projects looking at the timing. I've said again and again about how on-scene times have been going up, our call times have been going up for these patients. So there's a project going on here in the Northeast looking at that in some depth, and thank you to all the Northeast paramedics that are submitting data for that and have agreed to be interviewed. I do appreciate that. And we will have some data and some research to present probably next year, trying to really unpick what's happening in why the times have changed. We can show that they have changed, but what we don't understand at the minute is why. And this is one of the things that the Stroke Association has funded me to look into. So hopefully next year I might be able to come back and talk to you a bit more about that. Last thing I'll talk about, so we talked about the PASTA trial. There's not a direct follow-on, but led by the same team. There's a trial called Optimist, which actually officially started on the 1st of this month. So it is very fresh out of the box. And this is going to be a 5-year piece of research looking at thrombectomy pathways with a pre-hospital focus. It's going to involve multiple ambulance services. But as I say, very fresh out of the box, led by the team up here in Newcastle, but with partners right across the country. Not much I can say about this as yet, but just to let you know that these things are coming, people are doing it, there is research going on around this. We will hopefully have some good data on pre-hospital thrombectomy in the UK in the coming years. Thank you very much for listening to me tonight. Thank you very much for coming and dialing into this. I hope there's been something in there of interest. I think there's an awful lot actually going on in stroke care. I think it's something where we as paramedics can make a real meaningful difference to patients. We don't have much in the way of drugs we can give them, but our interaction, our identification, and our rapid treatment of these patients really does make a difference to them. And there's a lot of people, again, I have to thank for supporting my work, NEAS, the Stroke Association, the University, Josie and Emily, whose work I mentioned earlier on, and Professor Chris Price, who supported me for a number of years. So I'll finish off with what I think is coming next, where all this work's going to, what is going to change in the next few years. I think there's going to be more efforts to minimize pre-hospital times. I think the ISDNs will really drive this as a direct link to patient outcomes. I think the technology is definitely coming. I think more and more services and embedding that, and thrombectomy pathways, again, our interaction with these patients, our identification of these patients is going to be key to getting these patients the right care in a timely fashion. So this is what I think all of this work that I've talked about is leading to, and the big impact for us over the coming years. Thank you very much.
Hi, I'm Stephanie from CPD.me, and welcome to our webinars. Taking part in our great CPD webinars is an excellent way to learn new skills and knowledge in an informal way, either whilst at work, relaxing at home, or maybe enjoying some downtime in the park. Our webinars are designed to support our learning community, to work and learn in a relaxed and informal environment. And the great thing is, if you're a member of CPD.me, you can replay and watch these back whenever you like. Registering for a webinar allows you to attend the live event and interact with other viewers online, sharing both learning and links. Don't worry if you can't make the live broadcast because you're running out of time or get a late job. Simply register and we'll email you a fully edited copy of the broadcast the following day. Members of CPD.me receive a free CPD certificate for watching both live broadcasts as well as watching previous webinars. Premium members also have access to a personal CPD dashboard that contains priority booking for all our live webinars, plus over 500 CPD webinars and seminars on demand to watch whenever you choose, with automated CPD certificates. You can always purchase a CPD certificate if you're not a member, but it is more beneficial for you to join CPD.me and take advantage of all the benefits. One great feature of membership is that you won't have to pay for every certificate, and we will automatically add a copy into a professionally formatted CPD portfolio, accessible via your CPD dashboard for all our mobile apps. Join today, and we'll backdate any webinars that you've watched within the last 14 days. Now is the time to take charge of your CPD. Now is the time to join CPD.me.